So, welcome to another episode of Infinity Podcast, and I'm very, very honored to introduce to you a true superstar of anatomy, true superstar of aesthetic medicine in the world, one of the most sought-after guys, and if he's at a congress, people are going to come and watch. I'd like to introduce the genius that is Seb Cotofana. Seb, nice to see you.
Nice to see you as well. Thank you so much for having me.
Are you an American or are you one of us?
Well, I'm local.
You're a local.
I'm being here in Dubrovnik. It's almost like being back in the hood.
It is. So you've been here a few times before?
Yeah, multiple times here, but also because I'm born around the corner in Romania. And I grew up there until I was 10 and only then moved to Germany, which is still not far away from here, and only then moved to the US. So kind of like I feel like I'm local. I like this area.
Like you're back in the hood, yeah. Well, thank you for coming. It's your first time at the TAMC Congress, and we can talk about that as well. We're very proud to have you. And I was speaking to Tapan in another podcast on how anatomy is important, how we get a lot of people who don't know how to do things that haven't been taught, and I think anatomy is very important. So actually tell us why you think anatomy and learning anatomy is so important in aesthetic medicine, especially with injectables.
Well, I think anatomy is in some parts, and I say this as an anatomist, it is overrated. And the reason why I'm saying this is just think about myself. You know, I'm a professor of anatomy, went through all of these MDs, PhD programs, and would you consider me to be a great injector? The answer is no, even though I know anatomy. But what the true and the crucial thing about anatomy is its application, its clinical application. And it's one part to know the anatomy, but the second part, and which is the most important part, is how to apply it, how to make use of it in daily clinical practice. And this is what allows injectors to have confidence in their assessment, in their treatments, and in the outcomes. Because I sometimes compare anatomy with it's like a GPS, you know? If you know where to go, then you know what to do.
No, exactly. So, you know, if you wanted to give advice to some young doctors, I remember when I first started in aesthetic medicine, we were mainly doing nasolabial lines with needles. We were not thinking about anatomy. We were injecting hyaluronic acid fillers into the glabella wrinkles. You know what the advice was? Don't use Restylane. Don't use Perlane. If you remember Perlane, use Restylane. You know, it's got a smaller G prime. You'll be all right. You know, so we were injecting these. There was no cannula, and no, I didn't have any vascular compromise back then. It's probably later on when I started thinking about it more. Then maybe I had a few cases. Of course, we handled it properly. But what's your advice to the young person should they be afraid, or should they just learn their anatomy and learn the techniques to avoid vascular compromise?
I think what I would say to a young injector is it's not about if you have an adverse event. It's about when you will have your first adverse event, because they will come. There's no way around this. Everybody will have an adverse event. And if someone is on the stage and says, I never had adverse events, then the proper answer is, yeah, well, then you don't inject. And I think having this in mind kind of like tells everyone it will come. So either you be able to prevent it, or you'll be able to recognize it, and once it happens, then have your toolkit available and know exactly what to do. Have your ABC steps ready once it's coming in. But when it comes to adverse events, it's always like you need to be aware of what's coming. You need to be aware of the injection technique of the product, of the underlying anatomy of the arteries, and being aware creates a certain degree of, I wouldn't say fear, but I would rather say awareness. So in other words, like, don't be afraid to be aware. This is something that I think might be very important for young injectors.
Absolutely. Could you tell our viewers, and I think there'll be lots of young injectors and old injectors watching this, what would you consider the biggest danger zones for vascular compromise in the face?
Well, when it comes to danger zones, there are two types, vascular and aesthetics. And when it comes to vascular, when we look into the research in the current publications, it is nose number 1, forehead number 2, glabella number 3, and nasolabial fold number 4 when it comes to vascular. But when we think about how we all started, which area did we inject it first? It was nasolabial.
Yeah.
And the question is, why did we do that? Did we do it because we thought, well, this is where the greatest aesthetic need is? Or was it because this is where the companies had their first aesthetic approval by the authorities?
Exactly.
That's always the question, how to do this. But of course, I mean, approval has to be done, so it's proven, it's tested, it's evidence-based. But I do think nasolabial fold is the greatest risk area because it's so misleading. Everybody thinks it's so easy to do, just go for it. Everybody, novice injectors, start with nasolabial folds. And now, no, just don't. And even if we think that someone needs a nasolabial fold, we need to consider, well, we don't start the treatment of the nasolabial fold. If someone has the aesthetic indication, yes, there are nasolabial folds. Where do we start? Well, we start along the zygomatic arch, malar area, upper midface, and only in the last resort we go down piriform fossa or go then intradermally. So there are a couple of things how to avoid it, and this is where I consider as like prevention. Do you really need to go there? And if the answer is yes, I really need to go there, well, then be aware what you should do. Maybe if you want to treat the piriform fossa, maybe don't use a 27 gauge needle. Maybe use a 22 gauge cannula coming from horizontally lateral, use ultrasound guidance, and maybe this will increase your safety profile. I mean, even though adverse events happen with everything, needle cannulas, different sizes.
How often do you have like aberrant anatomy? So I think I told you earlier on, or maybe I didn't, I had a vascular compromise once, and I think there was a facial artery which was here somewhere, where it usually isn't. What's the percentage? I mean, how afraid should we be of that?
They are actually always there.
Okay.
Anatomy is highly unpredictable.
Okay.
There are statistical significant differences between the left and the right side of the face. There's no way around this. But especially when it comes to the arteriovascular system, there are some areas where you can predict with highest probability where the artery is. For instance, when the artery has to travel from neck into the lower face, it's deep crossing anterior to the masseter muscle. It's always there. The next stable location is at the modulus. The facial artery is always connected to the oral modulus. It's always there. And everything afterwards is just like, inshallah. Because what happens is, in the nasolabial fold, the artery is somewhere within the soft tissues. And one of the biggest misbeliefs that currently was revealed was the facial artery in the minority of the cases travels all the way down to the medial canthus. Because if you look at anatomy books, they always show facial artery goes from here, and then to the medial canthus, and then continues as the paracentral. It's not the case. This is only in 16% of the cases. In the majority of the cases, facial artery / angular terminates as the alar artery. It finishes here. So from here to here, there's no direct connection. So what has to be done, it has to go through the nasal vasculature. And the nasal vasculature is a part of the ophthalmic, part of the internal carotid artery, which provides blood supply to the eye. So in this way, we know that there's a lot of danger zones because we just don't understand these things, and we have these misbeliefs, and unfortunately also anatomists also contribute to this.
That's really interesting. Can you tell me one thing? We talk about aspiration quite a lot, and I do a lot of tear troughs, and I will often aspirate, and I will often get an aspirate, especially medially here. Is that important? Does it help us?
Well, aspiration, how to put it? I compare it a little bit to playing in a lottery. When someone is winning huge amounts, millions and billions, and you hear about the news in social media or in the radio, you ask yourself like, oh, I wish I would have, I also want that money, I wish I would have won that money. And then someone who's critically sitting next to you like, did you play? No, I didn't. So how do you expect to win if you don't play? The same thing with aspirations.
Yeah.
One thing that it's true about aspiration is if it's positive, it's positive. Clear. I mean, if it's positive, then you know. But if it's negative, you need to understand why it's negative. There are many reasons why it's negative. And one of the many reasons why it's negative is you're not inside the vessel. It could be because you have a new syringe, the plunge is all the way at the end, and how much negative pressure can you generate? 0.1, 0.2, that's not enough. What if you have a super high G prime and a 27 or 30 gauge needle? It doesn't work as well. Or what if you don't weight enough? Or what if you move? Or whatever. I mean, the multiple reasons, multiple factors why it's negative. But one of them is you're not in a vessel. But the problem is, and here I agree with the critical literature on this topic, is, it's like you cannot rely on when it's negative. Instead, I would say you can rely on it when it's positive, but if you don't perform, you will never find out if it's positive or not.
Is there any advice to our doctors? Sometimes, and I've been in that situation, you're doing a lip, and everything seems to be okay, and there's a little bit of a tint or something coming up on the lip, and you kind of go like this with your finger. It kind of goes a bit wide, but capillary refill still pretty quick, and just not sure, and it's the weekend. Have you perhaps, is it, are you in a vessel? Are you just outside a vessel? Would you recommend to everyone just Hyalase and sleep well over the weekend, or would you have any other advice?
I think the first and the most important thing is the well-being of the patient. Second is the aesthetic outcome of a treatment, because aesthetic outcome of a treatment is something that you do. It's like your work. And then what do I value more, well-being of the patient or my work that I put into this? And the answer is, well, you need to think about the patient, because, and this is unfortunately something that we forget in this field, is the most important person in the room is the patient. It's not us, it's not our social media account, it's not our following, it's not our company relationship, none of that. It's the patient. And if we think in this way, then I think we're getting back on the right track. But to the example, what you said is, I would use ultrasound. I would use ultrasound, put the ultrasound there, use the Doppler, and then see what the color box tells us. If I see there's a black dot, something that's hypoechoic, and then I see around silence, on the other side I see a really nice pulse, then I know, hey, there's an issue. So then I would use 50, 60, maximum 70 international units of Hyalase. Ultrasound
70 maximum, would you say?
Yeah, not more. I mean, there was a study that has shown, there are multiple studies, but some of them show like on average 61, 62. There was another study very early on in 2019 that said it's around 84.
For any region of the face?
Yes.
And so often we say we should repeat the Hyalase every hour and keep them in the office. Do you think that's overdoing it?
No, I don't think so. I don't think so that's overdoing it. But if you find the culprit pocket,
okay,
and if you inject
with the ultrasound,
with the ultrasound, if you inject directly into it, within 3 minutes it's restored. Cool. There were a couple of studies and cases that have shown within 3 minutes it's back to normal and totally fine. I mean, of course, you need to keep the patient for another 20, 30 minutes in your office, look, everything's fine, and then the patient can go into a weekend, and you can also go into a weekend and take your beta blockers.
I don't have an ultrasound, and I was talking to my chief nurse, Taya, the other day that we should buy one. And especially, not just, I've only had compromise a few times in my life, but a few times I wasn't sure. And the other thing is, I do danger zones. I do a lot of noses, I do a lot of the danger zones you mentioned. Why not get the ultrasound out and have a look at the anatomy, and then you're safer? So I think the advice for everyone is to get the ultrasound. Now I want to ask you, change the topic a little bit. I said at the beginning that you're a real superstar, and you really are. I have to say that there are not many names in aesthetic medicine we could say that about. We can say that about our friend Tapan, who was earlier as well.
Yes, Tapsi, yes.
But Taps, definitely. But you're one of the greats. And I think it's the way, when you do your anatomy, even Instagrams, I think even during Corona I used to follow you, and you do it with a bit of humor. You have is it Max?
Max, yes.
My son's name is Max, So you got your skull, Shakespearean skull, which you talk about, and it's a wonderful way where you draw, in a simple way, you describe the anatomy. And we talked a lot about vascular compromise, but it's not just that. It's the planes, it's where the fillers should be placed. It's how we get a good result and not a puffy face or a edema and so on, and that's part of it. So tell me a little bit about the Sebastian Cotofana Anatomy Academy, your academy. What's inspired you? What are the aspirations of your academy? And where do you see your academy going in the next years?
So, when I started educating, especially during Corona, I realized we don't travel, but I still want to reach everyone else. And then when Corona was over, you start to travel again, but you still realize, I cannot do everything. I cannot split up myself being there. But with more online being present and being on demand, I thought, hey, we should do that. So we created, a couple of years ago, Cotofana Anatomy. And Cotofana Anatomy is an online platform run by my beautiful wife, Mika. She is my boss. So
you have to listen to her.
Yeah, it's ain't no way around this. And she's right. In the beginning, I was like, but she is right, and even though it pains me sometimes to say, because she asked me then, did I tell you? I said, yes, you're right. But it's for the better. And this academy is an online resource. I have a lot of free content. For instance, I started recently a blog where I write about complicated research papers in simple, easy, understandable words, break it down into shorter parts because scientific papers are sometimes long, and it's free. So in other words, where I see Cotofana Anatomy going, it's a free resource for anatomical education, for understanding things, for being just in touch and up to date. And then, of course, there is the portal where you see a lot of injection techniques, anatomical layer-by-layer descriptions.
So there's lots of videos on the portal.
Oh my goodness, yes. There's.
How many videos do you have?
I think
many.
I think honestly we're getting close to 60 hours.
Wow. Yeah,
it's really a lot. I mean, it's really a lot of content, and it's tailored to aesthetics. It's tailored to basic anatomy, for toxins and fillers, and then we're going to competent levels and to expert levels. And expert levels contains adverse events and management, and everything is based on a paper that we just recently published where we introduce levels of competency in aesthetic medicine, because you don't want to have an injector in the first year treating noses. No, it's not.
No,
you want them doing something else. So we introduced 3 competency levels: novice, competent, and expert. And all of the content is structured according to this. So it's like we're providing a structured educational path on Cotofana Anatomy. And in addition to this, because I like doing drawings. And sometimes on my conferences, I made drawings on stages, and everyone said, oh yeah, can we have them again? And then I started, okay, I'm going to do this. So I opened a Patreon channel, and it's just me and a whiteboard, like really the old professor, me whiteboard. And it's just me drawing different aspects, drawing the mid-face, the forehead muscles, injection techniques, all of this. And it's easy to understand. So it's like, if you're new injector, you look at these Patreon stuff, and then, okay, now I want cadaver stuff. Okay, now you go to Cotofana Anatomy, and then you see all of these anatomical dissection videos and content.
Amazing. And I think in the modern day, this is exactly what we want. I think in the old days, we only came to congresses like TAMC, but now people, when they're at home, they want to have the tools at their fingertips. Of course, there's nothing like coming to see you live at cadaver courses or congresses like this. But I think I highly recommend your Cotofana Anatomy, and I'm sure a lot of people are subscribed already. So we're going to have to end this podcast quite soon, and I just wanted to ask you, it's your first time at TAMC Congress. I know we've spoken about it before, and with your wife in Paris, when she actually said to me, well, how come Seb hasn't been to TAMC yet? What are you expecting for the next 3 days here at TAMC?
I personally, I'm looking very much forward to this. I have very high expectations, no pressure. And the reason is because we're all friends here. We're all friends and colleagues. We know each other, and it's about the sharing. It's about sharing clinical expertise. It's sharing about recently published papers, and it's about the intimate discussions. You know, when you're at these massive congresses, you have no connection to the people who are on stage. You don't even know them. But here you know them. You have access to them, and when they leave the stage, hey, what do you mean by this? Kind of like, tell me a little bit. And then you start talking, and it's the connection, it's the human interaction, which you cannot have online and you cannot have through AI. So I think this is a beautiful way of connecting people, of educating people, and I'm very much looking forward to this.
Sebastian, it's a true honor that you're here because TAMC has for 7 years been an amazing congress, but I think with you entering our ship and joining us, we're just going to raise the level even more. Thank you for coming. Guys, the great Sebastian Cotofana. Seb, thank you so much.
My pleasure.
Thank you for coming.
My pleasure.
And we'll see you soon. Thank you.
Thank you.